time is limited. So I want to welcome you all today. We're going to be talking about choosing the right pain medication. But before I get into that, I did want to thank everybody for your support of our services. As you may or may not know, we are running a home-based palliative care program that has gotten very busy very quickly. So we are sending a nurse in. And by the way, I'm Dr. Kevin Cope, Medical Director for Mountain Valley Hospice and Palliative Care, if you haven't met me before. But we are sending a nurse in for our home-based palliative care program, and they are connecting with a provider through telemedicine, and we're offering palliative care services for patients that have multiple medical issues, but not necessarily ready for hospice care, which requires a 6-month prognosis. So that's taken off very, very quickly. In fact, we have a waiting list right now, but we ask you to keep sending your referrals, and we'll sort them out. Some patients that are referred for palliative care actually meet the hospice criteria, so they're moved pretty quickly to the hospice service. And then thank you for all the hospice referrals we've been getting. We've been quite busy, and ask that you keep those referrals coming. Just a reminder, we can take referrals from all 4 counties with no geographical restrictions. There's still some misunderstanding about that, including all of Montgomery County. So thank you for those referrals we've been getting. I'm going to talk about pain. Of the 330 million people who live in the US, pain affects at least, it's a large number here, at least 100 million people each year affected by pain, many of whom are inadequately treated by the healthcare system, according to a study conducted by the Institute of Medicine. And I think there's a number of reasons why that's the case, but we'll get into that. So we're going to be talking about pain, which is one of the most common symptoms that providers treat. We're just going to go over some basics, but hopefully give you a little strategy as you prescribe pain meds for your patients. So the underlying theme is that going to be that different pain types respond to different pain therapies, both drug and non-drug. And certainly would like you to utilize any non-drug type treatments before you use drug treatments, such as massage, physical therapy, heat, things like that. But we're going to talk about the 3 basic pain types. And as you might remember back from your days in medical school and your training as a PA or nurse practitioner, there's 3 basic pain types that we're going to talk about: the somatic, the visceral, and the neuropathic. And keep in mind that more than one pain type may be causing a patient's pain at the same time, which may affect your treatment of this and prescribing. So this is a kind of a busy slide, but I'm going to touch on it briefly here. So your somatic pain, as a reminder, it's tissue damage to the skin, the soft tissue, muscle, or bone. It's an aching, gnawing, deep, dull, sharp, stabbing pain, and it's well localized. Patients can often point with one finger to the location of their pain. And things like bone metastases, the cubitus ulcer would fall into that category. Then there is the visceral pain, which is pain in the visceral organs, such as gallbladder, intestine, liver, stomach, gastric. We've all suffered from indigestion. That's a type of visceral pain. Irritable bowel with the intestine. It's a cramping, squeezing, pressure, full, bloated type feeling, gassy, all over, more diffuse. And it can be referred, such as myocardial infarction, kidney stones, liver capsule pain, often referred to the shoulder. Can be colicky, can come and go, and it can be diffuse. It can be such as in the case of peritonitis, liver metastases, or adenopathy. And then there's your neuropathic pain. So the neuropathic pain is injury or inflammation of the nerves, often coexists with somatic or visceral pain. So keep that in mind, that it's often coexisting with the somatic or visceral pain. You get a burning, electric, numb, radiating type, shooting, tingling, hypersensitive skin. It's radicular, can be single or multiple nerve roots, such as herpes zoster or sciatica. Stocking glove, fingers and toes often involved, and diabetic or chemotherapy-induced neuropathies often cause this type of pain. So we want to match the drug and the dose to the pain pattern, and that helps optimize the pain control while minimizing the patient's side effects. And the other thing to keep in mind is time the medication to the patient's pain pattern. Some patients may only have pain, say, during a dressing change, and may benefit from getting their pain med 30 minutes before the procedure, but they don't need pain medications 3 or 4 times a day. They really just need it before the procedure. So keep in mind the timing of the pain pattern and the pain medication prescribed based on that pattern. So which classes of medications is right for your patient? We're going to talk about the basic types of pain meds, the acetaminophen, the nonsteroidal anti-inflammatories, the epileptic agents, the antidepressants, corticosteroids, and then opioids. So the 3 key principles for choosing a medication class. You want to keep in mind, does the drug type match my patient's pain type, such as the somatic, the visceral, the neuropathic? Is the drug type safe for my patient, and is it the lowest risk effective drug to treat my patient's pain? So let's talk about acetaminophen first. It's really very common, over the counter, and actually very useful. And it's indicated for the mild to moderate somatic or visceral pain. Can treat fever, headache, muscle, and general pain with it. It's available in many different formulations there. Does not affect platelet count. You want to avoid acetaminophen in people with significant liver disease or excessive alcohol use. And this warning came from the makers of Tylenol back in 2011. Just keep this in mind, that the maximum daily dose for acetaminophen products is 6. They lowered it from 8 pills per day to 6 pills per day, or 3,000 milligrams, which would be 6 of the extra strength Tylenol. They also changed the dosing interval from 2 pills every 4 to 6 hours to 2 pills every 6 hours. So keep that in mind. Then we're going to talk about the nonsteroidals. It's indicated for mild to moderate visceral and somatic pain. Indicated when treating inflammatory states. The acetaminophen really doesn't treat inflammation. The nonsteroidals do. So if there's an inflammatory component that you think to the pain, you may want to try a nonsteroidal. They're available in multiple formulations. However, you do need to be aware of the risks of nonsteroidal anti-inflammatories. So you have your bleeding risk, particularly the GI tract. You want to avoid these with anticoagulants, such as the direct oral anticoagulants, the so-called DOACs, such as apixaban, which is Eliquis, rivaroxaban, Xarelto, or other anticoagulants like warfarin or enoxaparin, the Lovenox. If a patient has a low platelet count, you want to avoid these. You also want to be careful if there's an element of renal dysfunction, diabetes, given the fact that there is usually some renal dysfunction, especially as it progresses, has a higher risk. And elderly with a creatinine clearance under 30, which is very common in people over the age of 75, there's increased risk involved with these nonsteroidals on their kidneys. You also got to be careful if the patient has congestive heart failure. There is some additive cardiotoxicity that's been discovered with the nonsteroidals, and the risk of renal failure. You also want to avoid it if patient is already on a corticosteroid. Um, the studies have shown that no nonsteroidal has greater analgesic efficacy than any other. Celebrex, which is still available, so celecoxib is the only COX-2 inhibitor and can still cause GI bleeding, but seems to have less incidence. And with nonsteroidals, especially in the elderly, you really need to weigh the benefits versus risk, long-term use, and generally long-term use in the elderly would be discouraged with nonsteroidals. So they may be good for short-term inflammatory pain, visceral somatic pain, but long-term, not a great one. And you also do want to consider the diclofenac gel, which is the Voltaren gel, which is out on the market now. It's actually over the counter for management of osteoarthritis. The studies have shown that just applying that over the joint area, the back, the neck, the knees, the hips, there's low absorption into the bloodstream. It does provide some relief, and it's generally safer if you're going to be using that long term instead of a nonsteroidal oral medication. Then there is the anti-epileptics, and mainly the gabapentin and pregabalin. Now, these are indicated for moderate to severe neuropathic pain, and you can use these in combination with other drugs. In fact, there's studies that show synergy if you use these with some nonsteroidals, such as naproxen. There's some studies showing benefits, increased synergy with the nonsteroidals and with trazodone and tramadol, which we'll talk about in a little bit. This is the mainstay for treatment of neuropathic pain. It's one of the few pretty effective drugs that we have out there for that. The downside is it does come orally only. But for managing that at home, that's fine. And the side effects are manageable for most patients. You do want to think about dose adjustment in patients with renal failure or renal insufficiency, the elderly, reducing the dose. And you do have to be careful with some sedation, confusion, ataxia, and edema. I find that some people are more sensitive to this than others. But generally, the drug-drug interactions are generally well tolerated. So think about using that when there's a neuropathic type pain that you feel there is a neuropathic component to the pain that you're treating. Antidepressants indicated for moderate to severe pain as a single agent or combined with other drugs. Useful for treatment of neuropathic pain, especially if there's a coexisting mood disorder and chronic pain conditions like fibromyalgia. So we're talking about the SNRIs, the serotonin norepinephrine reuptake inhibitors, such as duloxetine, Cymbalta being the brand name, and also the tricyclic antidepressants, the amitriptyline. And oftentimes, if a patient can tolerate it and they're younger, they don't have side effects from tricyclic antidepressants, you can add a low dose, which can be helpful. You do have to be cautious in older patients with the tricyclic antidepressants and those with underlying cardiac disease. They can cause anticholinergic side effects, including QT prolongation, sedation, delirium, constipation, urinary retention, and orthostasis. Just to note too that the SSRIs, which we commonly use for anxiety and depression, have not been shown to relieve pain. So keep that in mind. And then corticosteroids you want to think of. These are often useful, especially short-term, indicated for moderate to severe somatic and visceral pain, including the dexamethasone, the prednisone. They're widely used as a multi-purpose analgesic for bone pain, capsular pain, such as liver capsular stretch pain, headache, especially due to raised intracranial pressure, bowel obstruction. And the evidence supports the use of this, that they do tend to improve the appetite, well-being, and fatigue. But you have to be careful. They're good for short-term use, but think of the side effects. They can cause especially the long-term side effects, the adrenal insufficiency, the myopathy, the GI bleeding, avascular necrosis, osteoporosis, and fracture risk. But in the short term, you should probably let the patient know. I find insomnia is one of the most common, but they have been known to cause agitation, delirium, hyperglycemia, fluid retention, hypertension, increased risk of infection. And remember, when you have a patient on steroids and you're doing blood work, you're going to have an elevated white blood cell count, but that's not a problem. It's related just to the steroid. They should not be combined with nonsteroidals because of the increased risk of GI bleeding and no increase in efficacy. The last thing we're going to talk about, spend a little time on, is the opioids. So the opioids are indicated for moderate to severe pain as a single agent or combined with acetaminophen or nonsteroidals. They're effective across all three pain types: the somatic, visceral, and neuropathic. They're really the mainstay for treatment of moderate to severe cancer pain. They're very useful in hospice patients. Um, and they have the added benefit in the hospice patients too of patients that are having difficulty breathing. They help relax the breathing as well. And they are available in different formulations. Even a hospice patient, we can get that in transbucally when they're on an opioid. They don't affect the platelets, renal function, liver function, gastric mucosa. Um, and then you want to keep in mind that the drug choice and dosing adjustments are necessary. If you do have somebody with severe liver or kidney dysfunction, you may want to dose adjust. The side effects are manageable for most patients: the constipation, nausea, sedation. They should be tapered when discontinued, not just if they've been on them for a while, not just stopped abruptly. So I want to talk a little bit about opioid phobia, because we've had this pendulum in our country now with the whole opioid epidemic, where we've gotten away from prescribing opioids for patients. But I want you to think about the scenarios where opioids are useful for patients if you take the necessary precautions. So let's talk a little bit about that. The CDC came out with guidelines for prescribing opioids in chronic pain. And by chronic pain, we mean for more than 3 months. And we're talking about excluding cancer, pain, palliative care, and end-of-life care. So we're talking about your patients you're seeing in the office that have chronic pain but are not in a palliative situation or a hospice situation or cancer. When considering a long-term opioid therapy, you want to set realistic goals for pain and function based on diagnosis. You want to check that non-opioid therapies have been tried and optimized. So you certainly don't want to rush to an opioid. You want to discuss the risks and the benefits, including the risk of addiction, overdose. You want to evaluate the risk of harm or misuse. You want to discuss that the risk factors with the patient. Do they have a history of alcohol use, drug use? You want to check the PMP before you prescribe that, the Prescription Drug Monitoring Program. And this is something I found quite useful, is to check a pain management urine drug screen on a regular basis on the patients that you do giving chronic opioid treatment to. For two reasons. You want to make sure that, number one, the medication you're prescribing is in their urine, and that it's not being diverted. And you want to make sure that they're not on any other controlled substances that might interfere or interact with the opioid that you're prescribing. Now, when you order this, you do have to order a pain management urine drug screen. Just sending a hospital urine drug screen to the hospital will miss most of the opioids. So keep that in mind. The hospital can send out to their reference lab the pain management urine drug screen. You want to set criteria for stopping or continuing opioids. You want to assess the baseline pain and function. We're going to talk in a minute about the PEG scale. You want to schedule an initial reassessment within 1 to 4 weeks. You want to prescribe short-acting opioids using the lowest dosage on product labeling. match the duration to scheduled reassessment. And you want to follow up on patients who are on chronic opioids at least every 3 months and document the effectiveness and get the urine drug screens periodically. So let's talk. Here's a quick way to document in your chart about a PEG score. You can kind of do this over time when you see patients back for follow-up. It's one quick way to put a number down in the chart. PEG stands for pain, enjoyment, general activity score. So you'll ask them those 3 questions there. What number from 0 to 10 best describes your pain in the past week? What number from 0 to 10 describes how during the past week pain has interfered with your enjoyment of life? And what number from 0 to 10 describes how during the past week pain has interfered with your general activity? And you can take those 3 numbers, you can take an average of them, and that would be your PEG score. And then you could follow that from visit to visit and document, is the opioid helping the patient, and judging by their PEG score. You want to prescribe the lowest possible opioid dose. And generally, the feeling is to limit to less than what they call 50 MMEs or morphine milligram equivalents per day, if possible. And if a patient does require more than 90 MMEs, you should consider a pain management specialist, or also you should consider that this patient may be developing an opioid dependency, opioid use disorder, and refer them to a buprenorphine, naloxone, Suboxone program. Or if you do prescribe that yourself, that's a great way, as we do in our family practice. We send a lot of these people that do have issues with opioids, we put on our Suboxone program, and the buprenorphine is a pain medication and it helps them a great deal. So by MMEs, here's some common drugs, opioids that we use. Tramadol, a 50 milligram tramadol has 5 MME. Hydrocodone, 5 milligram is 5 MME. And keep in mind that oxycodone, a 10 milligram, has a 15 MME. So if you're prescribing 10 milligrams every 6 hours of oxycodone, that's already putting them over the recommended daily MME allowance of 50 that's recommended. So try and avoid those stronger opioids. Start out with the lower MME, the tramadol, the hydrocodones, before you would advance to anything stronger. Just want to touch base here about some New York State public health laws in this area. So because of all the opioid overdose issues, and the fact that the state is watching this, if you follow these laws, you will not have problems. So you want to limit the initial opioid prescribing to a 7-day supply for acute pain. If you have a patient on a opioid for more than 3 months, you need to put a personalized opioid treatment plan in the chart. Have examples of that. If you'd like, you can contact me, which is a written treatment plan that must be updated annually, talking about these different areas, so you can personalize your treatment to that person. Keep in mind that patients being treated for cancer that's not in remission or on hospice or end-of-life care, this law does not apply to them. And then the Narcan rule, public health law, just went into effect, that says when you provides that with the first opioid prescription of each year for use in a setting other than a general hospital or nursing home under Article 28, when a practitioner is prescribing a controlled substance to a patient, again, this is a non-hospice patient, that you would prescribe an opioid antagonist such as Narcan or naloxone when any of the following risk factors are present: history of substance use disorder, high dose or cumulative prescriptions that result in 90 MMEs or higher per day, concurrent use of opioids and benzodiazepines or non-benzodiazepines, sedative, hypnotic. So I've gotten into the habit, anybody above even a 50 MME per day, I give them a prescription for Narcan. We send that to the pharmacy for them. So So just in closing here, here's a little case study. Mrs. Jones, we see these type of patients every day. 70-year-old female complains of moderate joint pain and low back pain radiating down one leg. You evaluate her and believe her pain is related to osteoarthritis and degenerative disc disease with the radiculopathy. So how do you treat her? You certainly want to start with acetaminophen. I would start with 500 milligram, twice a day, and she could take an afternoon dose for breakthrough pain, heating pad, and a lot of times that's going to be enough relief for Mrs. Jones. She's happy with that. If you need to, if you feel there's an inflammatory component, you can consider short-term nonsteroidals. If the relief is not adequate, there is some neuropathic pain here. You want to consider gabapentin. If they're elderly, I usually start low, 100 milligram 3 times a day and titrate up. And then if the relief is not adequate from that, I would consider tramadol, 50 milligram 2 to 3 times a day, which is well below the 50 MME. And then if they're still on follow-up visits is not adequate, I would consider hydrocodones, acetaminophen products, 2 to 3 times a day, which again is below the 50 MME. You want to try and wean off if it's only during a flare-up. If you do need to prescribe for more than 3 months, please put that personalized opioid plan in there, update that annually, get pain management urines to make sure she's taking it and that there's no other controlled drugs in the urine. Um, so that concludes. I don't know if anybody had any questions. You can certainly email me. I know time is running out. It's 1 o'clock, and I know a lot of us have patients scheduled. So I would say if you have any questions, just shoot me an email. It's kevin.cope@mvhcares.org. So thank you everyone for attending, and we're trying to do this once a month just to spend a half an hour talking about a common symptom, a palliative care type symptom that we treat. So hopefully helpful too as you see patients on a day-to-day basis. So, all right.